I don't know. I'm not sure how to manage this with the crowd. For those of you who are here, thanks. Yeah, we can come up and just congregate here. Doug's going to film this for us. So for the people, because there is no time as we go into 3 and 4 to. I was thinking about just postponing it, but there's no time to do it. So Doug's going to film it, and I think I'll go through rather quickly so that the video isn't so long. People can watch it who aren't here. Natalie should have emailed out a truncated version of the previous slides that I had around this. I think I called it clinical integration shortened or something like that. I've done a little bit of wordsmithing on it since then. I found a couple typos, so don't worry about that. But we'll cover the piece to cover. First of all, I guess I should say, at the end here of session 2, any major concerns or issues that have come up that we need to address? Natalie, we have people, we need the evaluations for the session, right? Mostly done, or is that still being in? Yeah, just bring them in if you have a few minutes while I'm chatting to kind of fill it out. Just help us understand not only, the content, but the flow, how the flow went for you, how it fit around. I know Tom of the honor group had a couple of comments for me as I drove them back down after dinner. And they're really useful. Even, it's always a work in progress, so please do that. Any other announcements, Natalie?
Nope. Make sure you sign in if you want to see me. I know most of you are here, so if you didn't, I'll let you know. But other than that, come back.
Yeah, and then we're back in April. And it'll be a good week. Mark Roberts is terrific. David Eddy, obviously, on Tuesday. The trip on Wednesday. And I forget what happens after that, but it's a packed week again. It'll be pretty awesome. Okay, what we wanted to do with this part is cover the last piece of this idea called clinical integration, right? It got at the idea that in order to do this work, to move from projects to the system of production, you kind of had to have some concepts in mind. It was illustrated by Duran's trilogy, the model that you're going to employ. We've employed the model, right, of total quality management as modified by those folks back east, the associates in process improvement, really built on those core questions. What are you trying to do? How will you measure it? And what changes can you bring into the workforce, relying on the PDSA cycle? Move from the project phase to a system of production phase. It required the model, required a good data systems and culture that we talked about. We use this vehicle for culture and ATP, and then required some infrastructure. Tried to begin to make the argument that traditional divisions and departments of medicine and surgery weren't adequate. And so what's this infrastructure look like? And that's what we're left with, okay? The infrastructure and the nuts and the bolts of that infrastructure. Okay. So we were telling the story through Intermountain's lens of this thing called clinical programs. Clinical programs, an organization, a particular organization with particular leadership and team-designated structure, in this case built around almost things like service lines. You'll see when we talk about it, it's cardiovascular, it's women's and newborns, it's musculoskeletal, it's neurosciences, it's pediatrics and primary care. That's the easy part, getting into those groups based on what you and your organization and your communities need. The harder part then is investing in the resources to make sure the work gets done. So here's what is the basics of it. Integrated leadership, different than, again, the traditional structures of leadership that we've had in medicine. Nursing leadership, pharmacy leadership, physician leadership. Now it's integrated across those disciplines. We'll show that where, with rigor, like we talked about 2 days ago or whatever it was, we identify the important key processes that are clinical processes especially, that are requisite to those groups. Define the best practice based on literature and expert consensus. We've learned about how to do those techniques to bridge those gaps in the causal chain, as we said yesterday. To establish objectives that should be seen as tactics, the things you're going to do and the goals that attend to those things. You could put that in reverse order, set the goals, and then figure out tactics to achieve the goals. These teams are designed with resources to achieve the goals. So, you don't have to beg, borrow, and steal for the analytics. You don't have to beg, borrow, and steal for the help with writing and research for the measurement. Build out the comparative reporting in the dashboard way that we talked about yesterday, and then direct vehicles by which you tap into local infrastructure so that you can run the train all the way down the track to where it needs to be. Those are the key components, okay? Illustrate how that works out here in just a little bit. I think, just broadly, the keys to success is, I think actually the secret sauce is that integrated leadership. I've not seen on a large scale more things get done and get done well than when you partner up these professionals in their areas of responsibility aligned around these key clinical processes. It was illustrated by Don and Colleen. They came and spoke with you, didn't they? Don and Colleen, the cardiovascular, just illustrated by that. I think one of the best examples. This is hard to get, that consistent representation and participation. People are busy, you know, so this is the conundrum we're all dealing with. How do you get everybody to do it all the time? But that turns out to be a key to success. And the data systems really do turn out to be a key to success, as we've focused on this particular week. And that's why we spent so much time on it this week, is we wanted you to have an understanding not only of the concepts, but especially the practicality and expertise in measurement that you could bring to your teams that you might not have otherwise had before. The goals, a focus on clinical quality, we'll get to alignment, and of course board and executive level support. Next slide illustrates that a little bit better. I don't know if I said this in the last session. I was reminded of this. You know, the biggest thing that I did in my career with respect to this stuff was sepsis. And I don't know if did I mention the story where the board member called me out a little bit on that? So we'd done, I think, over 6 years, some important work, lots, dozens, hundreds really actually, of PDSA cycles around each of the components that might make up sepsis. And we designed a dashboard. The dashboard was inpatient sepsis mortality, you know, that was available electronically, just like we talked about yesterday. ICU length of stay, cost of care, and overall bundle compliance was on the main dashboard that we perpetuated longitudinally. And after about 6 years, the truth of it was my team had sepsis fatigue. They were tired of it. You know, we'd been burning on it for 6 years. They just didn't want to do it anymore. So we switched over, and I think we worked on, you know, CT scans and stroke and CT scans and pediatric closed head injury. It's about 2 years later that one of the board members came up to me and he said, "Hey, Todd, we've been keeping track of the sepsis performance. What's going on?" I had no idea. I hadn't looked at the dashboard in about 1.5 years. And what he had seen in this case, and the board had seen, because they continued to review it in the way that we talked about yesterday, is that our bundle compliance had begun to slip. And more noticeably to them at the board level, the mortality had begun to tick up in a way that was identifiable via the SPC chart, even for people like him without statistical training, a business person from the community. So that idea was one of the most direct lessons I had about how important it can be for an organization to have that ownership of clinical quality and clinical process management all the way from the top down to the front lines. And it was a really powerful lesson to me. So if you have this, count yourself as lucky. Even if you have one or two members of the board who understand what's going on, who have this from their business experience or from their hospital experience or whatever it might be strategic and pick those people out. Look at their CVs and introduce yourself. Share the successes you have with this project or even attending the course with them. It will generate more energy than you might think. Now, this list here is from the advisory board, so that, you know, when you go home, it's not just, hey, they said this thing at Intermountain. Here's from the advisory board, which all hospital executives have to listen to, I think, by virtue of their contract or something like that, right? I put the URL down here, and it's quite consistent with my list here. The system's top quality champions are the board and the CEO, not us here in this room. It has to be that way for it to move successfully. This, I think, is really important. Number 2 and number 3, they're tightly related. Final authority to approve and endorse these care standards that you develop is a system-level decision. When the MECs, if you're in a multi-hospital system, or the MEC begins to get at this stuff, they will inevitably, by virtue of what the MECs do, change it, tinker with it. Not understand parts of it, approve this part, disapprove that part. That's not what the MECs are built to do, and it's part of the reason that variation has been introduced into the system. Rich, you can think of lots of examples, right, within Intermountain Healthcare, where an MEC, let's say at Cedar City, has approved something, and up in Cache, the MEC didn't have the whole picture, and so they said no to it. And it just subtly and persistently introduces variation. So this is hard, this is easy to say, harder to do. You have to work really diligently with your CMOs, your CEOs, and your medical board to get that to be the truth. Then the role of the MECs is to give local input and promote adherence, but not to develop those care standards. Leave the MEC to do what the MEC is designed to do, and leave quality in a different place. This diverse work group, I'll illustrate here in a little bit, so I'll skip that. Centralized pool of experts. Yeah.
I'm sorry. Is that's coming off a white paper?
Mm-hmm.
Because as you said, in reality, I think that can be really hard to do. And I remember talking to a CEO of a hospital in North Carolina a few months ago, and their medical staff was almost largely one big multi-specialty group. So I think a lot, which therefore had a lot of control about what they were willing to do and not to do, and that was good. And that was probably one of the primary challenges for moving that hospital forward, was engaging that multi-specialty group and kind of getting a shared vision. So I agree with you conceptually. The reality is, I think MECs, particularly at some of the smaller places, can really hold a hospital hostage. MECs and the medical staff.
Yeah, so I think about smaller hospitals, and I think about this integrated multi-specialty medical staff with a slightly different twist on that, where at least early on, until this culture really began to change the organization, you'd have to use the vehicle, the MEC, to get this stuff going. White paper, ideal state, right, which can sometimes be helpful from the advisory board, but you're absolutely right. MECs like nothing more than to retain and control authority, privileging processes, and until that begins to shift, it's tough, recognize that. Centralized pool of experts, that is to say, house your expertise in an area that can then be disseminated more consistently and more broadly. This takes an investment from the board and the CEO, but it's a recommended way of organizing where even the planning and the conduct of clinical improvement doesn't get dispersed geographically and doesn't get dispersed conceptually, to introduce the variation that way. Multiple incentives, that maybe, Jason, that gets to your idea that multiple incentives or different incentives, different areas of ways of working might be required based on the local environment, the maturity of the organization. And then rigorous scorekeeping was their words. I don't love scorekeeping as a word, but essentially that transparency of data in the way that we talked about yesterday. So additional resource from the advisory board from 2016. I haven't looked to see if they have an updated version. They may, with some new value-based, some of the value-based initiatives, but that's one. Okay, so now just to dive into the clinical programs themselves. So it is built around a grouping of related clinical services. The core concept, as I mentioned, I think is that administrative partnership between administration and clinicians dedicated around a process of care. You'll see how that cascades down, and then that central leadership, as we talked about. Now, our organization, just like your organization, if you set this up at home, will be in constant evolution based on the needs of the healthcare environment at the time. When I started with the clinical program in intensive medicine in about 2007, somewhere in that neighborhood, it really was tightly focused on clinical activities. And we churned and burned on clinical activities and clinical processes. I remember distinctly, for a couple of reasons with Intermountain Healthcare, in about 2010, I was asked to do a whole bunch of stuff with respect to compliance. Okay, they put a compliance officer, And it wasn't because I was a rogue agent or anything like that, but they put a compliance officer on every team. We had some challenges, as everybody had some challenges with this, the world of regulatory affairs that were out there. And in emergency medicine, we had a couple of EMTALA issues, the Emergency Medicine Treatment and Active Labor Act. So we've focused on other things. We were like half of my meetings, it seems like, were devoted to compliance. That's how it goes some days. We're still in evolution. It used to be, this sort of stuff. And now, consult on staffing models, think about the equipment, standardization, and help advise on those purchases from a supply chain. Compliance, like I said, with medical necessity from the Medicare. Think about physician pay for performance. It's that alignment of incentives, the same idea. You're the one, the clinicians themselves sometimes have to be the ones who talk to the front line and figure out what incentives would work in that environment against what particular purpose. I mentioned supply chain, electronic health record, training clinicians not only about the clinical aspects but regulatory aspects that are just more prevalent now, and building that into the flow of work. And this coding and documentation turns out to be a big one. We've talked about how it's a type of a gaming the system, but it turns out to be a big one in terms of the performance on the scorecards and in terms of revenue cycle. So evolution of these things based on capability and the economic and the environmental need. I wouldn't say that all of them are appropriate, and some of them can be quite distracting. That means you will have to be stewards of that opportunity and those jobs as you go forward. Okay, we've tried to line if we're trying to given that expanding scope, when we try to put brackets around our clinical programs, it's around what we've called the fundamentals of care. You might call them your mission, vision, and values, or vision and values in your organization. Ours are 7, I think. Where'd they go? Yeah, 7. So here's the first: safety, quality, patient experience, access, stewardship, smart growth, and engaged caregivers. That the clinical programs now, moving out of just owning the clinical best practice guidelines, are around those fundamentals. And that is one tool that you'll see, or I should say one strategy that you'll see illustrated when you do the field trips next time to help keep these goals and missions in line against the entire organization. Our organization, just like every other organization, has had challenge in just having these goals and these projects just grow up organically because we want to. And it's super fun and terrific, but it doesn't give you often as much synergy, performance and synergy of reporting that you can get. So we try to align up to these fundamentals now. So safety, quality really is where the clinical evidence-based care practices live. Always keeping in mind patient experience, and especially now, you'll hear from, in session 4, I believe, Shannon Phillips, our Chief Patient Experience Officer, and Chrissy Daniels, who's from the Prescaney Group, about this idea, designing from the patient perspective. How many folks in here have a patient advisory counselor or something like that you can go to easily? Most folks? Okay, good. I mean, that's kind of a necessity of operations today. And if in the future, as you build your improvement teams, you identify a patient or two that would be willing to be a regular participant, the better off you'll be in terms of this. They keep track of Sutter, in fact. Sutter Health in California, a system comparable to ours, runs a sister training program course like this twice a year, and it's a rule that they have a patient on every improvement team who goes through the course. So like when you'd meet, like we just did, they'd have a patient on every improvement team. So patient experience, access, obviously, and then stewardship. That's our word for how do you keep cost affordable so that people can use care when they need care instead of deferring care until it's too late. Keeping track of per member per month and cost per case issues. Smart growth, thinking about where's the clinic. John, I think this was your question about specialty care, that the approach we used around DRGs would miss some things that don't happen very frequently. This is one thing where this is the first place it begins to pop up. Let's say I'll show you our clinical program, medical specialties. Where does rheumatology needed, for example, and help with that idea, and then keep the caregivers obviously engaged. Some of it boils down here. I think that was left off the previous list, but it's around evidence-based best care, right? Avoid unnecessary procedures in particular, which will set you up for problems. Okay, now other places are doing this too. I just put this list on here in my travels as I go around so that if you wanted to reach out to them, they've got people there to see what's different, what's about the same. Hoag in the Cleveland Clinic, they call them institutes. At Kaiser Permanente, they call it integrated care using KP Connect. Mayo Clinic, the Mayo Clinical Care Network. Advocate Health has APP, Advocate Physician Partners, and Providence Partners for Health, the umbrella organizations that do this as well. So lots of places to look if you're trying to get examples how you might build this in your areas. Okay, here's our 10 clinical programs. This is the highest level order where they're organized around really these service lines: cardiovascular, women's and newborn. Digestive health is one of our new programs that we identified and established because as we came, at least in this community, as our understanding grew, and to your point, we'd realized we'd sort of left this out. Consequently, all of our GI physicians, to start with, as an example, not really aligned in any particular way, culturally or operationally. We have a host of folks with chronic or potential chronic liver disease that we hadn't managed in any particular way. And whether this will, I think it'll stick, but just the idea around organizing purposely such that we could begin to help manage those conditions a little bit better. Oncology, obviously, especially in the age of precision genomics applied to oncology. Medical specialties, kind of a catchment for these disparate groups that we hadn't really managed well before either. Nephrology, rheumatology. What was some of the other ones that were on there? I forget. Immunology, that we're increasingly aware of as the science progresses, that needed, again, one, a home, a professional home, and two, access to the resources by which they could begin to sort of tick off these next series of problems that we hadn't done very well before. Behavioral health, obviously, surgical services, pediatric specialties, musculoskeletal, and neurosciences. That's the top level for us organization. Based on a key process analysis or based on the analysis of your communities and your needs, you would certainly organize a name differently, just based on what you need, right? This is the top level. That's the cascade, I think, that is important. Now, this is those programs illustrated in a slightly different way, now kind of in a vertical. And it's to make explicit the idea I've just implied before. What's then unique about, I think, this organization and these organizations, they exist across the country, is instead of, again, the traditional divisions and departments, you bring in and compose that team of the people who can manage clinical processes in that realm. So, for example, when intensive medicine was listed as a clinical program and I had emergency medicine as a sub-channel, there was a person on my team from imaging that was there every time that I knew. Right? They would come to the meetings, and when they were the expert on imaging, the process of how imaging is ordered, how is it conducted, what other things pop up in terms of contrast preparation, things that I might not know, we might not know. Always a member of the team, and they developed, just as they helped us develop understanding of imaging processes, we helped them develop understanding of emergency department processes. And so we became linked in that way. Becca Pond was my pharmacist for 5 years, where she would call me, I would call her, same sort of idea, terrifically powerful. We had a representative of patient flow. We didn't have rehab on our team, but it's on the list. Obviously, nursing was there and tightly integrated care management, laboratory, respiratory, pain management, resources for patient and provider publications, food and nutrition, safety, not only patient safety, but caregiver safety. We didn't have genetics, but genetics is available for the clinical programs who need it. Information technology, we had our dedicated team there, and supply chain as well. The organization had invested in the resources and the assignment of those resources such that the team could be constituted more broadly and then built around processes of care. As you build this out, if you build this out, just think about the benefit that this would bring, and do your best. It's just essentially, it's the teams that we've asked you to construct for your projects, just brought up a level, right? Just brought up on a systematized level in this case. As you organize your teams, you'll still have those people now around a process of care rather than generic team members who will be on your team continuously. This is one graphic, the way I like to think about it. You got the clinical leadership here. Typically, it's a dyad for us, sometimes a triad. Physician, administration, clinical operations. When you look across the organization, we're rebuilding the triad. We kind of merge those into one to save money, I think, and over a period of time, so it was a dyad, but now rebuilding the triad. And then the resources here to help design the data systems, the measurement systems, and implement the processes that are owned. So it was really hard as a clinical program leader to do, well, first of all, couldn't do this. You need that help. So the people that you meet with in these consultant sessions, that's really these folks, really from clinical programs that we borrow for the course to help. Data experts, process experts, who know where the data lives and how to organize it well, and then additional staff and system support to help disseminate. That's the workforce. I think it was maybe Jim who was talking about that a little bit the other day. So clinical management infrastructure and information management infrastructure. This is the generic organization that we have. The leadership of clinical programs, the teams themselves, the individual clinical programs and overall clinical program leadership report directly to our executive leadership team. No layers in between. Just right there that they report on a month, almost on every other weekly basis to executive leadership. Physician lead, operations lead, the support staff as we talked about, and then direct links where it's reproduced in the triad level, in this case at each of the hospitals. It would be reproduced or should be reproduced on the outpatient side at each of the clinics or specialty offices that exist. Physician lead, nursing lead, and ops officer. So direct links, this gets you to the front line. Obviously the front line still exists right down here, and that's one of the challenges, is when you're here, how do you get down here? You sort of have to use this mediation sometimes a little bit, and that, every layer that you bring in provides a few challenges. That's how it's meant to get at least really close to the front line directly. Here's how it looks for neurosciences if Corey were here. There she is here, linked with Rob Hesh. Their ops officer is Don Zarco in this case for the triad, to make out the triad. With the data manager, outcomes analyst, telestroke manager. So Neil in the back, Neil, raise your hand. You are the data manager or the outcomes analyst, yeah, joining the team. Telestroke in this case, an administrative assistant. Now, this is the area that we're going to come and talk about in the last little bit of this. In the brown is what we call development teams. So you have the clinical program leadership and the service line of neurosciences. Then neurosciences combined with executive leadership, combined with the front line, essentially has to say, let's do a key process analysis. And against that key process analysis, what bubbles up on the things that we need to manage? And for them, it turned out to be this. They needed neurosurgical organization. They needed organization and resources around epilepsy, concussion, spine surgery and spine rehabilitation, stroke, and cognitive, which essentially is dementia for our elderly population. On their key process analysis, those are the big things that bubbled up. Then essentially they say, okay, these smaller buckets have been identified. We're going to build, at least in our nomenclature, what we call development teams around those issues. And development teams, this is where the work happens. This is administration leadership. It's the development teams where the work, essentially the project level stuff that we've been learning about this course, begins to happen. And that's where I think the fun is, okay? So there's one example of how that works for medical specialties, a little different, obviously different development teams, but the same thing, leadership and development teams.
Just out of curiosity, is there then like a spine person in musculoskeletal and a cognitive person in medical specialties? Or, because I mean, I like the overlap, I'm getting a sense of this now, but I'm also like, oh, what does that do when you sort of rearrange these?
Yeah, so no, we don't want to have the duplication of efforts here, and sometimes you have to make choices, right? You could put, spine could end up in musculoskeletal, for sure, and cognitive, as you say, it's a spread and a balance issue for them, and it's how, as we reorganize clinical programs, how we decide to apportion things. Yeah, so no, nothing special, but you want to avoid the duplication, for sure. Now, that said, when you look at the spine team, it will include orthopedists, obviously, rehabilitation folks. It'll try to break down those silos that could otherwise emerge. When you look at cognitive, it will include, just like we had on this thing, it will begin to include the folks who are necessary, who come from all sorts of disciplines and backgrounds, so it doesn't look like it's a neuro thing in the end. It just looks like the neuro leadership is owning it, organizing it, and then the development team themselves, people from all walks of life, so they can own that particular thing. Yeah, Jason.
And this is across the whole, like that neuroscience team, for instance, is across the whole of Intermountain. Because then I was asking Corey that, at the hospital level, you still have more traditional departments, sections. How do you handle things like medical staff credentialing, OPP, all that kind of good stuff?
Yeah, so great, terrific question. I mean, it may have slipped by. The traditional divisions and departments for all those purposes still exist. I mean, the bylaws were written with those things in mind, and back in the day, and changing bylaws, as you know, is like a Herculean work that takes, Rome could rise and fall before that was done. So these sort of exist. I sometimes think they're sort of in parallel, but kind of they're more horizontal and oblique across all of those things. So you have to preserve the traditional divisions and departments and their jobs, and then they exist as another dimension in parallel or horizontally with them. And in truth, at the hospital level and at the leadership level, you often see duplication, the same person appear in different roles with different hats. So quite common to see the chair of the Department of Medicine at a particular place also serving a role in clinical programs. And that's handled through budgeting, the traditional vehicles of budgeting and contracting. And there is a synergy that often goes there a little bit. Some of the strongest efforts I've seen have taken advantage of that synergy. On the other hand, you get some chairs of departments of medicine and surgery who just can't do it. We just have no interest in doing it. And so that's where the parallel structure or the horizontal structure comes in. To your point on the local, Kevin Call is a neurologist, a stroke neurologist, who is at Utah Valley Medical Center. For the system then, we've plucked him up. We said, Kevin, you're terrific. Can you help lead the system effort? We obviously pay them for that at that time. And then Kevin also keeps his hat on as the leader of the Department of Neurology down at Utah Valley. So just one, you see it in different forms, in different ways.
Are all of the 10 clinical programs are the leadership typically based here at this campus, or you mentioned Kevin Collins down in Utah Valley, but could the medical director be at Utah Valley or something?
Yes. We've tried you have to find, when I mentioned, in Ryan's, mentioning Ryan the other day, when musculoskeletal, failed twice, what the message of that is you really have to find the right person. For different reasons, the right people have often seemed concentrated in the Central Valley. I think it's a selection bias in bit, right? The leaders here, the people better, you work with them, you trust them. So you're tempted naturally to go down that route. It turns out to be associated with weaknesses on the other side. you increase the selection bias, number one, and then people at Utah Valley and people at McKay who, rightly think of themselves as talented, hardworking, interested people, develop a us versus them mortality. Oh, that's just the folks in Salt Lake trying to tell us to do something again. So we very purposely tried to disperse geographically. Then that creates its own set of problems. You can imagine 300 miles away, and if I get a leader 300 miles away in St. George, how do they stay? How do you stay tightly linked? So everything has challenges, but we've worked hard to avoid concentrating it in one particular place. So Ben Fox, in fact, is a neurosurgeon down in St. George. Tanya's here in epilepsy because we just don't have that. Eric Robinson, concussion, is up at McKay. Steve is here. Steve Warner's a spine surgeon here. Kevin, as I mentioned, and cognitive is here as well in Salt Lake. So little pluses and minuses on both sides, if that makes sense. Other questions, thoughts on that? Okay. Now, so development teams, and I think this is almost the last thing we're going to talk about. Led by, again, a dyad in this case. When you need the operations folks, the administrative folks, you'll typically, because of scarcity of resources and budget, kind of run up the chain and borrow it. But they've got access to the same resources, sometimes even more, and who are always aligned with the clinical programs. And now you make up the team, as John reminded us, of those essential to the process. Essentially, you're creating, in this case, I've mentioned this before, I remember, divisions and departments of the medical condition. So, a division of inflammatory bowel disease, a division of sepsis, a division of pneumonia, a division of cognitive behavioral dementia, a division of, as you heard yesterday from Brenda Reese-Brennan, a condition of division of mental health integration. You're creating these divisions around conditions that patients experience rather than the traditional divisions and departments of medicine that span not only the site of care, but the process of care, from well to latent to acute to chronic to post-acute rehabilitation, and even all the way to hospice at the other end, if you think about it. And again, this is where I've had the most fun in that process. So that usually has a team leader, a core work group, as we illustrated on a previous slide, and that includes now, you need knowledge content experts who are going to help you build and design this evidence-based best practice guideline. So this requires really reaching out and finding the clinicians or the people who have real expertise in this particular domain, whether it's pneumonia or sepsis or inpatient medicine, hematology, oncology, Bill, for yours. Academic, they provide the academic detailing and forecasting. I gave the teams the charge that I said, I want your medical knowledge in this area, you're on this team, to be 6 months ahead, to have a view 6 months ahead of where we are today. That means, you attend the meetings, that means you read the literature, you're on the listserv. So I wanted to know what's coming down from a pharmacology perspective, from a diagnostic perspective, 6 months ahead of time. Geographically based, I mean geographically dispersed here. This is where I really try to reach out and get people from different parts of the organization, different locations of the organization, so that they can then be the eyes and ears in that team-based communication structure that we talked about last session. And it includes now frontline clinicians. This is where you identify the talent directly and begin to pull them up into your work groups to help you, because you're not only designing the evidence-based best practice, but you're designing, remember that, how it fits into the flow of clinical work. And nobody can do that except the people who are doing the work, fundamentally. So this is where that lives. And the staff support as necessary to get the work done. Content expertise in terms of the roles: set goals, track implementation, develop and maintain the content, review and approve clinical operations standards when necessary, and occasionally do case reviews and system-level peer review turn out to be the main roles of the development team. Now here's kind of the recipe, the nuts and bolts that we have. Now, John, this is formally where that question lives. These teams fundamentally are managing clinical knowledge. That includes having eyes on, recommendations for, making sure the needs of the specialty and the subspecialty clinics are represented. And we've sort of had a cascade map to ensure, that things like rheumatology, immunology, even before we organized around directly, didn't get missed, because it's a real risk of it in the way that you talked about. So generate the best practice guideline, blend it into the work, design the outcomes tracking system. We talked about that. Coordinate the decision support. The patient and professional education materials is the development phase, the maintenance phase. Keep it current 6 months down the road. Do the academic detailing for the frontline teams. Different clinical programs do them in different ways. We do learning days. We do special conferences. We do webinars. We send out stuff. There's a bunch of learning and communication apps available for the phones that everybody has, right? Has anybody used Basecamp before, for example? Yeah, so there's some out there. They change a little bit, but there's different ways to do that. But they're the ones who do the academic detail in whatever way they can, the referral clinics we manage, and help manage the specialist care managers. When people are involved, patients are involved with specialty care, they typically have chronic, sometimes tough diseases. Their expenses are always high. They almost always then need to be associated with a care manager to help not only with the management of the specialist illness or condition, but to help swing the patient back when they can be swung back into wellness or managed chronic conditions. And so these teams will have that as a part of them as well. Now, always paid. You can't just walk up to clinicians and say, give up your practice, change your life without that compensation. At the minimum, it's probably for the top clinical program leaders for Intermountain Healthcare, about a 0.5 FTE. Sometimes it turns out to be a full FTE. To my back of the napkin estimations, at a place like Intermountain, so 22 hospitals, $5.5 billion in revenue, we directly spend each year here for the physicians, the nurse, the administrative leaders, the data folks, and the analysts like Neil, about $8 million a year across those core folks. Maybe a little bit north of that, $8 million a year. Direct investment in the people. Probably against an organization like ours, it helps connect and align with when you look into local resources, probably another 200 million a year. So at baseline, we're kind of talking at 200 something million a year in just investment resources in this structure, such that this thing can move at scale. So it's not a small lift, right? And it wasn't built overnight. It took learning and patience and understanding by people in charge of budgets, Intermountain Healthcare, that this recipe sort of works out and plays out a little bit. So big investment in the leadership, guidance councils, which is sort of an aggregation of the leadership, and then the development teams. Goal setting is tricky. We had a history of, like I mentioned, just this organic goal setting, goals that would just sort of pop up out of nowhere. It was somebody's special interest. They had a particular problem, so let's set a goal around this particular thing. In fact, that's how, as I mentioned, the febrile infant protocol came onto my desk. We'd had a couple of children who weren't recognized as having serious bacterial infection. They had bad outcomes, and so the need was, let's do this sort of thing. And it became a goal. The goal was, let's develop one of those things. Now, was it right? Yeah. Did we need to do it? Absolutely. Would we have done it absent those things? I probably wouldn't have surfaced up that particular way, but that's representative of how these things just sort of popped up based on a need. The goal setting now, again, the alignment issue that you're going to see on the trips next time are really important. Alignment around those fundamentals with the key safety, quality, stewardship, access, engaged caregivers flowing down, and then the frontline team still, though, recognizing the main themes of the organization, develop goals, frontline goals, bottom-up design that scoop up those top-level things in the way we talked about yesterday. So that's the clinical teams determines the potential goal against those aligned core principles and strategy, assess the gap between what you have and what you want, that data development system we talked about yesterday, figure out what baseline is, design and implement to reach the particular goals that are set based on that data. It's cascaded up a little bit, so again, there's no surprises. One of the big principles of improvement theory, no surprises for the people up top, no surprises for the people down at the bottom, constant communication. Education, implement with iterative testing through a PDSA cycle, and then transparent metrics using the dashboard principles we talked about. Now, we're developing, I put these next 3 slides in there for you, and they're worth looking at some point. We've tried to develop a little more, this sort of gets at the key process analysis. You do the key process analysis about what's important in your clinics, but against all the clinical candidates, let's say just clinical candidates for improvement that might come down the pike, how do you choose where you might be successful? Is there some strategy, some rigor that you can bring even to that process that will give you a better chance of being successful? And this is sort of their first go around in that with that particular goal in mind. So there's a search and develop part, what we call a certify, and this is to make sure you've got the bricks and mortar in place to get the work done. Prioritize the improvement efforts, then move to spread, and sort of simultaneously along with the spread, which is why those arrows in there evaluate. Spread is tricky, as we've all talked about, and so some rigor around that will be helpful. So that might help you a little bit. In the certify, I'll drill down on that just a little bit. We've actually developed a tool, happy to give it to you if you want, that essentially is a process by which you look whether something is shovel ready. You've heard that term with respect to government initiatives, whether it's shovel ready. It has a table of contents, checklist of major activities, a background problem statement. You ask the clinical teams, the sponsor essentially, give us a background problem statement beyond why this is important to you. Identify, in particular, the leverage points and the evidentiary support behind those leverage points. This is essentially asking somebody to do a little work uphand on the causal chain idea that we talked about yesterday. What are the leverage points that you have against that conceptual model? And what's the evidentiary links of that leverage point to our true outcomes of interest, right? Do a little bit. Is there a sponsor, a team leader, and a team in place who can own it? Is there an eligible cohort? Are there good evaluation metrics, both for the clinical costs and service outcomes? Do you have a conceptual flow diagram and design that's done? Have we done an expected benefit analysis? Has someone done that, an ROI on cost, service, or medical, right? What's the assessment of the field? You go out, we actually send people out now to the different hospitals or clinics and ask clinicians, if we did this thing, what do you think? If we were going to design and redesign, what do you think? Are you ready for it? Becomes an important part, and then a summary of what the impact might be. This is what the scorecard looks like against those things in the end. But it may be worth looking at for some of you just to think, is there some methodology, is there some rigor that we can bring to the selection before we invest all the resources and time and energy that we can go through, okay? Can be real simple for these things, sometimes just standing orders, or as complex as what we call here care process models. So let me talk just a little bit of the last thing about care process models, and then we'll be done. Care process models for us are the highest level of developed content around a clinical condition, okay? It's what is produced by these development teams when it's done in its most full and rigorous way. So it's not just an alert, it's not just an order, set, or guideline. Those are easy to do, right around, let's say, GI bleeding on the unit. You could develop an order set around GI bleeding. Simple to do. It doesn't equal a care process model. Care process model, by definition, will have to have typically a development team who owns it, which means, I should have said this first, it's been identified as a key clinical process, and so the resources have been identified with the development team to own it. It has to, in the end, have an evidence-based best clinical practice guideline that spans sites of care and disciplines of those who are involved in it in the way that we've just described. It has to have a dedicated dashboard and data mart, right, in the way that we described yesterday. And it has to include patient and provider materials. They have had to been developed, patient and provider materials that are designed to help everybody know that this thing's available. So it takes a fair bit of effort to become a care process model at least within our parlance. It's like, remember that old Schoolhouse Rock cartoon about how a bill becomes a law? It's like that thing. You have to become a law in the end and get a little ribbon or hat or whatever they got, right? So we've got about 120 of those that span these clinical programs. Everything from prevention, chronic disease, acute disease, procedure stuff, imaging guidelines, based on the evidence-based care, which are designed to improve outcomes. That's our core bits. 104 of those, about 120, excuse me, of those that we've developed over the years. We even, just to show you how nerdy we are, we even developed a care process model for developing care process models. It's a little wonky, right, huh? Meta. Yeah, really meta, huh? It's cool. So if you want access to some of these, feel free to ask. I used to have a document that had the hypertext links to them. And so it was one Word doc, one, I think, 2 or 3 page Word document with the hypertext links organized by clinical program. Those links broke in the last year, so I'm rebuilding that document now, maybe able to send that out again. And I didn't have this care process model for care process model development. And I actually quite like this one, and this is a useful one for you to look at. Maybe I can send it to Natalie later today to send it. It's about just the recipe by which you go about it. Yeah?
Everything is available on the website. I tried to click like all the care process models that are available on the website. Which website? Like if you type like the ATP process model, you can click every.
Is it from ours? I didn't know if it was from our, or from Intermountains or from ATP?
From Intermountains.
That's what I thought. Yeah. Okay. Yeah. Maybe it's still available, public facing. Sometimes the public facing is off, and sometimes it's open. So we've always had the opinion that this isn't proprietary knowledge. We didn't develop the evidence base around stroke. We've tried to aggregate it in a particular way and, lay it out as a flow, but it's not proprietary. So we've always had just like we always talked about in this course, to share. And I'm working on, I'm trying to do a single document, with the links, but if you can get it through the website, maybe I just publish that website, it'll save me lots of time. Okay, send me that URL, because I don't even know it. It's Intermountain Healthcare. IntermountainPhysician.org. But you have to log in to IntermountainPhysician.org. Don't you have to log in to IntermountainPhysician.org?
Not for me.
You're on the
Oh, all right, whatever. Who knows? No wonder we get hacked all the time.
Yeah, that's a good point, because we're in like Intermountain internet links right now.
Download it all while you're here.
Yeah. So let's see. Who was the organization last year that took healthcare data EHRs hostage? There was a few of them that took them hostage and they had to pay rent. So way to go, Jonathan. If we crash today, I'm going to be ticked. Okay. So here's a few of them. Elective labor induction. And this is the last thing. A little bit of work, couple of slides on the steps you might go about in developing something akin to this thing. And by the way, it looks very close to everything that we've talked about, right? So collect and review the information, do a little whiteboard session in the way that we've talked about, draft a hard copy. Okay, now you've got a hard copy, circulate it for review, multiple cycles. As it begins to solidify, then get to work on the workflow documents. That is the order sets that accompany this, the outcomes tracking system. We talked about that yesterday, whether or not it can be integrated into the EMR with appropriate decision support and the education materials. And that's it. That, I think, is the last one I had. That's just what we had yesterday. That's it. Okay, does that make sense? So the infrastructure turns out to be as important as the culture. The infrastructure turns out to be as important as data, as good data. The infrastructure turns out to be as important as the improvement model. Think about how you build teams, longitudinal teams, to organize around process of care to handle this thing. And until we built this, until we got successful at building actually each of the components of it, as I said yesterday, we're never able to show any ROI across outside of a single unit in this way. So a powerful lesson for us. And turns out to be pretty, and it's why Hoag and Cleveland Clinic and Mayo and Providence and all those organizations are doing it. Okay, questions, concerns? Any problems? I asked before, any problems that have come up here in session 2 or anticipating session 3, Mike?
Yeah, so I guess my biggest problem is that we don't have the infrastructure and we don't have.
At home?
Yeah, $8 million to invest. So I think it'll be, I don't want to be negative, but I think this is wonderful. But I think as Rich and I were talking during dinner on Wednesday, this is a very unique place. And it's great, but I think some of these things will be hard to bring home. Even
sure.
like the physician leader, half an FTE, some of them upwards of a full FTE.
So what do you think? What does the class think? As the last thing to say for Mike and for us, when you look around, and we recognize this is the case. When you look around and you don't see the train track there, you don't see the trains. What steps, Jonathan?
Yeah, I think we're in the same shoes. We're one large community hospital and one small rural hospital, and we don't have the infrastructure either. But small organizations sometimes have some advantages over large ones. One is the number of layers between the top and the front line are fewer. So, that's a strength to play to. But, I know we can't build the same infrastructure, but we could take some steps forward. We might not be able to do this for 8 clinical programs, but we might be able to do it for 1. And we may not be able to have a data manager and a data harvester and 4 or 5 different flavors of data people. But we might be able to have one who is maybe a little bit more able to do multiple parts of that and be close to the front line, I guess.
Yeah, so that's one option. So Jonathan's getting option 1 here. And Mike, remind me the nature of your organization.
I'm at a tertiary academic.
Tertiary, yeah, okay. So these are, sometimes they can be tricky. Because really solidified, sometimes even ossified structures in leadership, right? With particular ways of doing things that are steeped in a tradition. So Jonathan's getting it sort of option 1. Any other thoughts on this, by the way? Here's what I say, Mike, is in what I hope. Number 1, I hope you have fun. I hope you, right, have fun learning this. I hope you have fun doing it. And I hope you've got a microsystem back when you get back home that can then begin to build it on a very small scale locally. Like, so your department chair or a particular senior leader can help organize just in your unit. And you do it there in your unit, you do some cool things. And that's in fact how we began, right, at the shock trauma unit up at LDS Hospital. And you do enough to engage the people you're working with on the front line, and you do enough to engage the level of leadership above you. And one of 2 things will happen. Either that'll start to move at scale, you'll rise up in the leadership chain. Who knows when you'll be, CMO or something like that. And then you've got a different opportunity. The other part is, Mike, I think in truth, there's been a lot of people who have come through a few people have come through the course, and this is option 2. Because I think, 1, these principles, we described them from a system perspective today. If I didn't make it explicit, they apply just as well in the division, the department level, the frontline level. And so you build it and engage and have fun there. I've seen a few people come through the course, and essentially at the end of it, they said, or a year or 2 later, I like this stuff. I believe this stuff. I love this stuff. It gives me this sort of insight, an opportunity that are different that I was looking for in medicine, that I really need in medicine based on who I am. I don't think I'm going to find it here. And so you go elsewhere. And that happens occasionally, right? Self-selecting. And it's just true. We're pretty mobile people in medicine who the skill sets translate almost anywhere in the country at any particular hospital. And we have opportunities for mobility that lots of folks don't have. That's not perfect, but we have opportunity for mobility that lots of folks don't have. So I see one of those 2 pathways. Have fun locally, and then just see what happens with your leadership development and the organization development. And then sometimes you say, you know what, maybe I'll go, live and work in Southern California, which isn't a bad place.
There's another couple of ways of thinking about it. I mean, some of the FTE things might not be initially available, but for example, in my division, what we've been able to do is actually advocate for me to have a portion of my FTE covered by doing quality improvement, and it was through iterative processes. Some of the smaller projects demonstrated value that was more than, say, my entire salary for the year. So they're happy to buy a portion of my salary to sort of offset some of the time so that I can do this kind of work. The other is that I love the CPMs. I'm using the CPMs at Yale. You know, it's great that you guys have already created the algorithm for managing depression, and I just, you know, use it as well.
Yeah, steal it and modify it.
Yeah, exactly.
Piracy turns out to be one of the great principles of quality improvement. So.
Oh, yeah, so I did a couple. So one was looking at quality assurance. So we were able to comply with one of the regulatory bundle measures that was just a lot of difficulty complying with. So for
Thanks, guys.
they weren't able to do it unless they had a dedicated physician who had enough purview to really work on it. So for them, it's a big regulatory piece. The other was I was shifting some workflow, so I did some workflow redesign so that residents admitted overnight, so used a different workflow template than they used to before, and it sort of saved the regular daytime physicians a lot of time, and so we calculated, and they were like, oh my gosh, this is great, you know, and all I did was like create a new template, convince the residents to do it because it was good for their education, and then you know, there was a lot of pushback, but eventually went through, so.
Terrific, and the fun thing is you smile as you say it, tell that story, which is great too, right? And that's like at Yale, right? So if anybody, you know, when you think of Yale, you think of the most, you know, sort of one of the most prestigious and structured, I don't want to use the word ossified in this case,
It's true.
institutions in all of America. So terrific, yeah. So maybe usually, Mike, I do better at conveying that message along the way. You know, again, our story, and certainly not replicable overnight. This thing got built over decades, right? The thing that we just went through. But the principles of just how you're thinking about organizing and the infrastructure that's required to do this is a key part of the lesson, key part of the curriculum. Yeah.
The other piece I was going to share is that sometimes the work doesn't happen at the academic center. So my chair loves researching ketamine and loves doing, basic science research. His sort of shop is not going to sort of sponsor the entirety of doing this kind of work.
Absolutely.
Whereas the hospital system I'm part of, the ranks within there are much more interested in this because of operational efficiency, really having dollars associated with it. So me being sort of tethering the academic and the hospital system work, it's actually a really interesting place to play.
That's a terrific point.
Yeah, and you get to leverage the coolest new innovative treatments to sort of doing process improvement, and I think it's actually a upside of being at an academic center, even though you might not do this kind of organization.
I mean, I can't remember if it was you who said this or I'm gonna mess up his name, which is funny for me. Jim
Rennerson.
Thank you.
Yep.
You know, the leadership of this organization did the 2-day retreat and came back and said that they're in the business of clinical medicine, as opposed to they're running hospitals where doctors and patients happen to come. And, you know, truthfully, it's a simple statement, but I kind of see it as profound because even in our smaller ship, I don't know that we're in the business of clinical medicine, quite frankly. We're not really set up to deliver optimal care at the bedside. Then there's a lot of silos and other compliance barriers and other things that get in the way. We have several other business entities that may impact or limit our ability, like I said, to really provide for the clinical services that we need on the hospital side as well. And so it doesn't really, it doesn't make sense. And I think we need fundamentally a reorg and a reprioritization if we're going to be successful.
Yeah, that's true with most places. We've evolved, and it's just the nature of, what medicine is. We evolved into these structures that aren't designed to own it. That's the infrastructure piece. You got to have somebody, something who owns this, and you have to invest in it, believing in the mechanisms that Looming just illustrated again. Okay, well, end of session 2. Good work.
It's great.
So much.
Thanks, Josh.
We'll see you in a month and change. Call us, email, whatever, if you need questions along the way. A few of you have done that, and hopefully I haven't missed anybody in getting back to you. But don't hesitate to reach out. We're all part of the family. Okay.
It's really good time.
Travel
All
safely.
right, thank you.
You get on.